I'll be talking about topical cyclosporine eye drops 0.09% in severe dry eye prior to cataract surgery in rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune disorder connected to ocular disorders such as corneal inflammation and lacrimal gland destruction that leads to dry eye and corneal staining. The occurrence of post-operative corneal melt is a devastating complication seen in rheumatoid arthritis if the inflammation is not under control. The purpose of this study is to study the cataract surgery outcomes in severe dry eye and rheumatoid arthritis patients with topical cyclosporine 0.09% eye drops. What was the need for the study? In spite of systemic immunological mediators within normal limits and the rheumatologist consultation, the severe dry eye was still persistent in all these patients. So for local control of inflammation, cyclosporine 0.09% eye drops were started preoperatively and the effectiveness is studied. So what do we choose, SICS or phaco? We have selected phacoemulsification as the SICS wound is larger and induces more inflammation and may lead to scleromalacia. This is a cross-sectional observational study done in ophthalmology department in Ramaya Medical College Hospital. Inclusion criteria: all patients diagnosed with rheumatoid arthritis, severe dry eye with Sherman's less than 5 mm, T-but less than 10 seconds, and all patients are undergoing temporal clear corneal phacoemulsification with IOL implantation. Exclusion criteria: any other ocular surface disorder leading to dry eye, previous ocular surgeries, patients on any long-term medications. We have included 3 patients. Detailed ophthalmic evaluation with dry eye evaluation is done. Sherman's test, tear film breakup time, Oxford grading for ocular surface staining. After complete pre-op evaluation, the patients were found to have severe dry eye and surgery was deferred. Then these patients were started on cyclosporine eye drops 0.09% TID, and the immunologist opinion was again taken for adequate immunomodulation. After 1 month, Sherman's test improved and the ocular surface stabilization was achieved, and the patients were taken for cataract surgery and the outcomes are studied. The case 1 is a 40-year-old female patient, case of rheumatoid arthritis, referred from immunologist with complaints of diminution of vision with visual acuity, counting fingers at 2 meters. Cornea, there were minimal staining according to Oxford staging of staining. There was immature cataract NS3. Sherman's test was 0 mm and T-but was 2 seconds preoperatively. After 1 month of starting cyclosporine eye drop 0.09%, Sherman's improved to 10 mm and T-but stabilized to more than 10 seconds. Post-operatively also it was maintained. This is a case 2, 60-year-old female patient, known case of rheumatoid arthritis, again referred from my immunologist with diminution of vision, with visual acuity 660. Anterior segment, there were punctate staining on the cornea and conjunctiva with immature cataract NS2. Sherman's was 0 mm, T-but was 1 second preoperatively. Starting on cyclosporine eye drops for 1 month, Sherman's increased to 10 mm, T-but more than 3 seconds and was maintained post-operatively. And there was clear cornea. Case 3, 80-year-old female patient, known case of rheumatoid arthritis, came with sudden complaints of diminution of vision and in the right eye and sudden onset pain. She gives history of right eye cataract surgery, that is SICS, done 1 month ago. Right eye, on examination, the vision was counting fingers half meters. Anterior segment, there was corneal thinning noted at 1 to 3 o'clock hours. Superficial vascularization was present. Circumcorneal congestion was present. Pupil sluggishly reacting. PCR is in situ. This patient was diagnosed with corneal melt and underwent corneal gluing with bandage contact lens. After 2 to 3 months, there was reepithelialization noted in the areas of corneal thinning and the right eye was stabilized. Considering this patient as a one-eyed patient, we decided to take her for a cataract surgery for the other eye. The vision was counting fingers 3 meters and immature cataract was present. On evaluation, left eye, again Sherman's was 3 mm and T-but was 5 seconds. After starting cyclosporine eye drop 0.09%, Sherman's stabilized to 20 mm and T-but more than 10 seconds, and post-operatively also it was maintained. Discussion. The first, Pragna et al. Talks about the visual outcomes and complications in dry eye disease following cataract surgery. Here the results were visually, visual outcome was significant. In the second, Young Chung et al. Here they have spoken about the effectiveness of cyclosporine 0.05% post cataract surgery, and they told after using for 2 to 3 months the ocular surface was stabilized. So conclusion, rheumatoid arthritis associated corneal melts have significant ocular morbidity and requires early and aggressive treatment. Integrated approach to systemic diseases along with immunologists gives compromising results, so timely diagnosis and preoperative approach to dry eye is very important. Using cyclosporine with steroids and lubricants reduces the complications like corneal melt. This is the conventional what we use, 0.05% cycloimmune and ristasis emulsion. This is SICWA, this is newly FDA approved, there is no conflict of interest, no financial disclosures. This is 0.09% what we have used in our study. So happy patient with tears and a happy doctor without tears. Thank you.
this study was specifically for cyclosporine, or you were the 1 month period you were using other medicines?
No sir, it's exclusively cyclosporine, but with lubricants, no steroids in it.
How long did you continue cyclosporine post-operative? How long did
Since we considered 0.09%, the drops which we considered was little on a costlier side. So we continued for 3 months post-operatively, sir. After that, we slowly tapered down to 0.05% cyclosporine.
And how long did you follow those patients up?
The patients are still following up. They are doing fine. The ocular surface is stabilized, sir.
If you have, what is the longest follow-up here?
This 1 year follow-up we have, sir.
What lubricants were you using?
Sodium hyaluronate.
So there's a difference in lubricants also, is it not? You have CMC, HPMC, sodium hyaluronate.
Yes.
So don't you think that makes a difference? So you have put all patients on cyclosporine and sodium hyaluronate.
Yes.
How much is sodium hyaluronate? What is the cost?
Around 4.
Isn't this a costly study to be doing on patients? Do you think all patients can afford that?
Yeah, that was one drawback of our study, but we wanted to try with the better lubricants which had which can be less frequently used.
Oh. Thank you, Doctor.